So let's get started with acid base. One of the things that go with fluid and electrolytes are acid base. Now, we're going to go through this. Some of this I've repeated in other lectures. But anyway, I still want to go over this just to give you everything that I think you probably need to know, along with all what you're studying to make this work. So let's get started. Of course, we've got our learning objectives. You can read through those for yourself. But this is definitely looking at electrolytes, the way our bodies deal and distribute fluid into compartments and in and out. We talk about that, the shifts that happen. And so these are your learning objectives. Just read through and then let's keep moving on. So water, composition of body fluids, water. The two largest parts of the body are water and electrolytes. Water serves for four functions in our body. It's a vehicle for transporting substances to and from. We need to move it as much as we can. It aids in heat regulation, so it keeps us cool. It assists in hydrogen balance in the body, and it acts as an enzyme. It has enzymatic action of digestion. So more or less, keeps us cool, keeps us balanced with hydrogen. It helps with digestion, and it transports what we need here and there. It also keeps us lubricated throughout all of our joints, everywhere. So, so we've looked at this before. It's more than half the body's weight is water. We're made up of 70%. It says males approximately 60, females 50. Numbers vary based on different books, but go with the numbers. It's a lot, guys. We are made up the majority of water pretty much. Infant and elderly, of course, are affected by this, and we've already talked about that previously. I'm not going to repeat that in lecture, but just know, infants and elderly dehydrate much more quickly than grown or normal adults. People with comorbidities or disease processes can have issues too with dehydration and overhydration. So it's something to always think about because we want to study everything across the lifespan. So we need to look at like infants, we need to look at children, we need to look at adults, and then we need to look at our elderly. And especially this semester for my students, our focus is on the elderly. So this continues on. I said it already that infants and elderly become more dehydrated more rapidly. Infants' kidneys reabsorb less fluid. So the kidneys of the infants are still developing. They're not there yet. That's why. Elderly have less antidiuretic hormone and diminished thirst sensation. So what happens is they have less of the antidiuretic hormone and they have a diminished thirst sensation. So they don't want to drink. They don't have a desire to drink because they don't want to drink. They'll go, no, I'm not thirsty. No, I don't want anything to drink. Then they're not going to drink enough to stay hydrated. The one thing that you need to make a note on is if you have elderly patients or clients, you need to encourage them to take a sip of water, to take a drink, because they're going to probably not do it. So we need to try to help hydrate them to the best of our ability. But know that it's not something that they control. They have that diminished thirst sensation. Also, too, I want to make a little side note. The elderly have issues with enlarged men, have issues with enlarged prostate glands. Women have issues with prolapse and bladder issues. And so they'll have incontinence issues. We talked about it in a previous lecture on elimination. But if they take a diuretic, they're going to have to go to the bathroom and they're going to have to get there quickly and they're going to have to go a lot. And so a lot of them are worried about having accidents. So what they'll do is not drink, not take their diuretics, kind of just stay dry so they don't actually urinate on themselves. So it's also another thought process that you need to kind of think about is what's going on. But we have things out there. They can wear Depends, we have pads, all of those good things to help so that you can get out there and do the things that you need. Remember, water is critical to maintaining homeostasis, and we've talked about homeostasis. So let's look at sources of water and avenues of life. We're talking about intake and output. Now, I want you to look at this. Intake is oral food metabolism, and it totals out here about 2,500 milliliters. You can see that on the slide. Then we look at output. And when you're looking at the output, we have urine. We can urinate it out, micturate, perspire or sweat it out. We can poop it out, fecal matter, and we can breathe it out. So we expire it and there's moisture in the air. But note that those numbers, intake and output, are 2,500, 2,500. Now, do we want our INOs to be equal, or are they going to be equal? We want them as close to equal as possible, but they're not going to be equal all the time, but they'll be close, and that's what we want. Sometimes you might have a little more intake than output, and sometimes a little more output than intake. But still, we want equal or close to numbers. I also want you to make note, go back, review your CNA numbers. You should have learned in your certified nursing assistant courses how many milliliters is a coffee cup, how many, if they drink a cup of coffee, how much is milk, how much is this, that, and the other, so that you will be able to accurately document their input. Also, remember, a clear liquid diet is anything we can see through that is liquid at body temperature. So Jello, we have the Jellos and the broths and those things. As long as I can see through it and it's liquid, then it counts. Also, if you look at a liquid diet where they can have other things, anything liquid at body temperature. So we can have ice creams, those things can turn, jellos, we can have creamy broths, milk products, things like that. So we definitely want to go back, review that. But as nurses, I want you to go ahead and remember, anytime you flush an IV, it counts as intake. If it's 10 milliliters, it's 10 milliliters of normal saline. That's 10 milliliters under that hour. That should be documented. If I'm taking a bag of solution, if I'm doing an antibiotic, or if I'm giving normal saline, it needs to be counted. If it's a maintenance fluid, IV fluid, it's hourly. If it's a antibiotic, and we're not counting on the hourly, like this amount, this amount, this amount, then at least make sure that you put it in as 240 milliliters or 100 milliliters, or however much the bag is. It will tell you on the bag the amount. You need to make sure you document it. Anything that flushes into a body needs to be counted, and it's equal, or the same, I should say, for output. If I draw out of a drain or I empty a drain, that amount of fluid, whatever it is in that drain, counts as output. So if they've got a wound vac and we've got a lot of stuff coming out from that wound that's into the wound vac, we need to count that as output, because there will be liquid and fluids pulled from the body through that wound in the process of hopefully healing that wound with the wound vac into the cartridge. We need to get that stuff up and out. And so we need to count it because it is output. If they are connected to suction on the wall through an NG tube, that is output. If they have a Foley bag, that is output. If they have a fecal bag and we are gathering the information on, they're having liquid diarrheas and we can collect it, we need to measure it for output. Point to the story is everything in it should count and everything out should count. So go back and review those numbers. So intake and output is so vitally important. So to calculate a 24-hour I&O, you want to add up all intake numbers, then add up all output numbers. You subtract your input from your output, and if the number is a positive or positive, the patient has a positive I&O. They're a plus with a little circle. They're positive. If they are negative, if the number is negative, then the patient has a negative balance. They're deficient. There's a deficit. So what does that tell me? If I'm positive and I have a lot of output, more intake than I have of output, then I'm looking at possible fluid overload. If I have more negative, my output is greater than my intake, which gives me a negative number, then I am more dry or deficient of fluid. So if I have a patient, this is an example of a patient that, let's say, has congestive heart failure. So we know that they have a big flabby heart, it will not pump efficiently, and they have trouble with fluid or volume. So they have to weigh themselves every day, all that good stuff. So we have a patient, they've been drinking, not really following the doctor's orders of what they should do to maintain their intake and output. They're just drinking tons of fluid. So we have a large number. And then our patient's output is less than their intake. So they're on the positive side. So they're positive. They have more intake than output. So they call their doctor. The doctor says, take 2 Lasix or 2 furosemides today. Let's pull some of that fluid off so that you can efficiently function without overloading your lungs and your body with fluid. So they give them, the patient takes the 2 Lasix or the 2 furosemides. Then they start to urinate, and they urinate and urinate and urinate all day long, right? Just mass quantities of urine are starting to be pulled off. Then in the next 24 hours, we look at the intake and output. And if our intake is down, because they're going to start to watch what they're intaking at this point, also check time, do what you're supposed to do, drink the amount of fluid you're supposed to, but they should have a greater output number because Lasix or furosemide is a diuretic. It's going to pull volume in and then out through urine. So it pulls it out of the body, down, concentrates through the kidney, and then they pee it out or urinate it out. So that's what we want to look at. So if that's the case, then I know if my output on the second day after I've given the 2 Lasix or the patient's taken the 2 Lasix or furosemides is greater or more than the intake, then they're on the negative, which means they're drier, or we're getting the results that we want. I hope that makes sense to you. So just remember, if I've got too much going in and not enough going out, I'm positive. If I've got too much out and not enough in, I'm going to be negative. So let's look at this. If I'm nauseated and I have diarrhea, I'm sick. I've got this GI stuff, right? If that's the case, and I am just unable to barely eat popsicles if I'm lucky, one here and there, and I feel like crud, I'm running a fever, all of the good things of having the GI bug, right? The flu. So if that's the case, I have very little going in. But guess what's coming out the other end? Diarrhea. And if that's the case, that's a lot of volume coming out the other end. So when I add up my intake, looking at my output, even if I can't measure the diarrhea, it's in the toilet, I'm at home, I can't measure it, but I've had 5 large loose stools. I know that my patient is going to be negative. And because of that, meaning I have less volume. So something's got to give, right? So that's a brief kind of 24-hour I&O. and then looking at what we're looking at. If it's positive or negative, when we get those numbers, what does that mean? So the first lecture for my class was the heavy lecture. It was on the electrolytes, and we've talked about them, and we'll look at them again a little bit here. Um, for my class, they're just having to learn the first four, which is sodium, potassium, calcium, and magnesium, because they'll learn the rest as the semesters go along. But we have minerals or salts dissolved in body fluids. These are electrolytes. In solution, they break it up into ions. Ions have electrical charges. Remember that. Cations have a positive charge. Anions have negative charges. So each cation must be balanced by an anion. The major source of electrolytes is diet. Now, I want to say that and stress the word diet, because if you listen to the first lecture that I did for my students, I talked about a few things, and I also referred you back to your ATI book that they have little charts with what foods are high in potassium, what foods are high in calcium, so that you can look at that. We all know bananas have potassium, right? So if you see a banana in something, that should be an automatic trigger. But what else out here in the world has potassium? And that's what you need to go look at. What foods that you aren't familiar with that you would want to tell your client or patient to eat to get those electrolytes. So make sure you look at that. I love this. This is a very brief, but it is perfect because I am a one sentence kind of person when it comes to notes and stuff, even though I talk a lot. Sodium, water regulation and balance, that's what it does. Potassium, we're looking at nerve impulse transmission, muscle contraction, plasma, acid-base balance. Calcium, muscle activity, and blood coagulation. I said it the last time in the lecture, is if you have a low hypocalcemia, you're not going to clot. That's what coagulation is the clotting of something. And we're going to coagulate it. It is the clotting of blood. So if I have a low calcium, I'm not going to clot blood. The other thing, just FYI, that interferes with blood clotting is a low temperature. If you're super cold, you're not going to clot. So where this really plays into is post-op surgical patients. They come out of surgery and they're cold from being in surgery, and that's part of it. And then also lots of times the calcium will be on the lower end. So we want to make sure we warm them up and replace the calcium. Magnesium, nerve impulse transmission and muscle contraction too. There's your four that we're talking about. We also have phosphate. I left it on here. It's ATP production. We know that's the energy that's needed. And chloride is hydrochloric acid production and acid-base balance. It's married to sodium. And bicarb. And bicarbonate, I do want you to kind of highlight, because in this lecture, we're going to talk about bicarbonate a little bit. And you do need to kind of understand it. It deals with acid-base balance. Okay. So here's your major electrolytes, their normal ranges. You do have to know these four ranges for testing purposes. You need to know sodium. And it varies. These vary from facility to facility. But if you know sodium's normal balance is between 136 and 145, because that's what is in the books we use. I always memorized it 135 to 145 because I do better with those kind of numbers. But if you know it's in that world, you will be okay. So that if I have a sodium level of 130, it's low. If I have a sodium of 155, it's high. So I'm either hyponatremic or hypernatremic. Same with your potassium, 3.5 to 5, and that's about everywhere. We don't see much variation on that. Think cardiac when you think potassium. Sodium, think neuro. Those are our two major cations, and I want you to think that way about them. calcium and magnesium play into this, and we see a lot of nerve impulse things with this, and muscle spasms and relaxing of muscles based on calcium and mag. So they all play and do these different things. When you're learning these, and we'll talk about them a little bit further, make sure you pick out the things you don't know. Most all of them make you kind of lethargic, or you have something change in LOC, level of consciousness. But specifically, there's little things that each of them have or do that affect the body. Those are the focus. So there are things in our bodies that are non-electrolytes that we have to have. Amino acids or proteins, glucose, that's our sugar, and that helps with energy, and fatty acids. These things we have to maintain to have homeostasis, but they're not electrolytes. They remain bound together when dissolved in body fluid. Just FYI. When healthy people are eating normally, non-electrolytes circulating the body fluid will remain stable. It goes back to diet, guys. You know, the biggest thing out there right now is how do we get healthy? And everybody's got a pill or they've got a gummy of some form, you know, they're doing all these things. But truth is, if we really look at our food intake, our diet, and we really look at our activity and we really look at our fluid intake, if we're drinking the water, if we're eating the foods, and if we're exercising, we can be healthier. Now, I'm not making light of other things because there's things that we can use to help, and I know it's a struggle. I struggle. Who wants to go after work, after school, after all the things and walk or do something? None of us. We're exhausted, right? But we need to make that time because we will feel better and it is good for us. So, just a thought. A non electrolyte that's a fluid is blood. It's our normal circulating blood volume is 4 to 6 liters. So it's kind of important to know because volume is volume, but we've got to have volume in specific places and specific things, specifically blood. And we need 4 to 6 liters to live, to have homeostasis, to be able to function. It's composed of erythrocytes, those are your red blood cells, leukocytes, which is your white cells, platelets, which is your thrombocytes, and it's carried in a liquid form, which is your plasma. So we look at these things because if we're low on red cells, there's something going on. If we're high on white cells or low on white cells, there's something going on. Platelets are what help us clot. We need platelets to clot. We have to have those thrombocytes. So this is an introduction to blood for you. I don't need my students at this point to know anything about blood transfusions or anything like that. I just do want you to know, though, I do want you to know 4 to 6 liters of blood is the normal blood volume circulating in the body. And it's composed of erythrocytes. Just know what an erythrocyte is. So if you see that in a question or you see that in a lab value or a doctor's talking or a nurse is talking to you about something and you hear erythrocytes, you know that's the red cells. Same with leukocytes, platelets, and then of course we have plasma. So the thing with blood is plasma, proteins, and colloids contribute to plasma osmotic pressure, big words, which keeps fluid in the vascular compartment. So more or less, we've got to have proteins and colloids that contribute to this pressure. Our bodies has osmotic pressure built up within systems within the body. So that's how things stay where they're supposed to stay. Because have you ever wondered, have you ever thought about it? You know, why is it our bodies just don't go and just everything go wherever it wants to go? We have specific things in specific places and they stay there or they fluctuate back and forth to where they need to go. It has to do with osmotic pressure. It has to do with keeping things where they should be based on components. And this is where we see different things, where we have things like, you know, where we can change things with IV fluids. We can change things based on different colloids, different things. We can make things shift. We can shift volume out of circulating volume into out of that system and then out of the body. So there's different things that happen. So think about this. When you have plasma, if we say that plasma is what contributes to plasma osmotic pressure, which keeps fluid in the vascular compartments, that's our vascular system of our body. If that's the case, if I have high plasma, and am I going to, if I have an increased plasma volume, what is my blood pressure going to be? It's going to be higher. If I have low plasma circulating, I'm going to have volume. I'm going to have what? I'm going to have a lower blood pressure. And the reason why is it has to do with what's in that vascular space. Plasma, anything that alters body fluid volume also will alter our plasma volume. Just FYI. So our plasma is affected by it. Remember when we looked at the blood components on the slide prior? The liquid form that makes it go around in our body is the plasma. So that's the volume piece. The rest of the red cells and the white cells and all of that, the thrombocytes, all of those things, those are in that plasma and they go around and they do what they need to do. But the plasma is that truck that pulls up and says, hop on in, guys, we got to go because I've got to get from here to here to here to here to keep that body alive. Plasma volume affects blood pressure. We just talked about it. And the volume can affect circulation. So you think about how it works. Our blood pressure, and you'll learn more about blood pressure when we get into perfusion, but our blood pressure has to maintain, right? You took blood pressures and learned normal blood pressure volumes. So if we have higher ones or lower ones, there's issues going on. There's something happening and we need to look at it. So if my plasma volume depletes, my blood pressure is going to go down. If my plasma volume increases, my blood pressure is going to go up. Saying that, if isotonic solutions, and we'll talk about them a little more here, but if isotonic solutions, which is normal saline, D5, LR, but if I put those in through an IV into my vascular system, it is equal to our blood. It is the closest thing to our blood, our plasma. It's the closest thing. So we put it in the vein, and what it's going to do is stay in the vein. And because of that, we'll fill that vascular system back up, raising our blood pressure back up. I want you to think of it like a hose. Have you ever been out squirting a hose, cleaning your car, watering your garden, doing something with water in a hose, whatever you're doing with it? If you have a brand new hose, it's got a big circle diameter, right? And it's kind of hard on the outside. It's going to maintain that diameter, that hose. So I've got this vessel that's this big, hard, open vessel, right? That's my vein. So if I turn on the water barely, how much water is going to fill that big space? It's barely going to fill it, isn't it? So at the end, what's going to happen? It's going to trickle out, right? Just a little bit. But if I turn that water up a little bit more, I'm going to have a normal flow, right? I'm going to have enough water in the hose to go in that diameter of that vessel to go through it and come out and have a good strong stream. But if I open that water, if I take my spigot or the and turn it all the way up where I'm full blasting volume through that hose, meaning I have got it going on, I am pushing it through, what happens? I have a massive stream come out of the end of my hose and it's going to go further and I'm going to have more volume or more water coming out at a faster speed. Same with our vessels. If plasma's circulating through and all around in the body, if I don't have enough, it's going to trickle just barely through, right? and I'm going to have a lower blood pressure because my body can't, it has to have everything flowing normally to maintain normal blood pressure. If let's say I have normal blood pressure and I open that spigot wide open and I flow 2 bags of fluid into that vein, I'm just going to pour volume in, say normal saline, which is isotonic. It's going to keep it in that vascular system, in that vessel. Then my vessel is going to be at a high pressure, right? It's going to be high pressure coming through. And what's that high pressure going to do? It's going to drive my blood pressure up. I hope that visual can help you understand that. If not, I'm more than happy to explain it further. You can email me, message me, do whatever, and I will get back to you. So this is just distribution of body fluids we talked about the other day. I'm not going to spend too much time on it. Intracellular within the cell, extracellular is outside of the cell. We're looking within and around the cell. So when we're looking at that, our intracellular major cation is potassium. It wants to live in the cell. Extracellular is your sodium. It wants to live outside of the cell. And sodium and potassium don't like each other. So if sodium comes into the cell, potassium will go out. And guess what follows sodium but water? Water's its stalker. It loves it, right? It's the lover of it. So it's going to go wherever sodium goes. So we can push things in and out of cells, and we're going to talk about how we do that here in a second, but we can do that and we can make that happen. And when we do that, different things happen, causing potassiums to go up and down, sodium levels to go up and down, things to happen to our cells and what happens with them. So that's why it's kind of important for you just to understand. Don't get bogged down in this. Don't go, oh my gosh, all this chemistry, what am I going to do? Make it simple. Inside the cell, it should be potassium. Outside the cell, it should be sodium. That inside the cell is intra, right? Intra. And extra is out. Who's outside? Those extra people, right? Woo! I'm an extra person, kind of, sort of. Anyway, but just think of it that way. Make it as simple as possible. Outside is the sodium. If one goes one place, the other goes the other. And that will help you. I'm going to read this to you. I'm just going to let you take a look at it, read back through it. It's just what all I've just said. Transports the nutrients. It's regulated by the renals, metabolic, and neurologic factors. And it's high in sodium content. That's our extracellular fluid. So these are fluids that are unique in compositions. You can test these for glucose, protein, white cells, red cells, um, bacteria, malignant cells, and pH. We have aqueous humor, and I do want you to learn that as a term. What is aqueous humor? It's not a joke. It's not a laughy thing. It's in the eyes. That's the fluid in the eyes. We have saliva. We can look at that. Cerebral spinal fluid, pleural peritoneal. These are words you need to learn. Synovial and pericardial fluids. Go look them up, excuse me. But they're in different parts. Pericardial's in the heart, pleural's in the lungs. We can look, peritoneal is in that abdomen, in that space there. Synovial, I think, is in the, I want to say spinal cord. GI secretions, fluid in the urinary tract system, and lymphatic system fluids. So those are transcellular fluids, and we can test for different things, just so you know, but they are fluids and you need to think about it. If we're made up of all this liquid, it's everywhere, isn't it? So let's talk about intravascular fluid. So if intra is inside, it's the intravascular fluid inside the vascular system. The fluid within blood vessels, that's what we're talking about. It consists of plasma and fluid within the blood cells. Contains large amount of proteins, electrolytes, which help maintain intravascular volume. So we can look at things. We have serum studies. If you hear the word serum, you're going to think blood. So these are blood components can be drawn, serum lab draws. The intravascular space can be either arterial blood or venous. That system is what we talk about when we're talking about intravascular fluid. So, movement of fluids and electrolytes, water taken in by ingesting fluids and foods, and through metabolism, we move this. That is our digestive tract. That's how we do it, and it moves through metabolism. Thirst mechanism is in the hypothalamus of the brain. It regulates thirst based on concentrations of electrolytes. If you've got a high sodium level, remember that if we're hypernatremic, you're going to have an increased or severe thirst, right? First thing you want to do is drink. It's like eating Asian cuisine or Chinese food. I mean, I love it. I could eat it every day, but no lie, I eat it and I could drink a gallon of water. I'm very thirsty based on the salt content in it. Or you eat salty potato chips, you want to drink, right? Or peanuts, stuff like that. So we definitely can see with a higher sodium level we want to drink. Um, Remember, with the thirst mechanism, as we age, it goes away. I want to say it again to you because it's important to understand that. They're not going to drink. What does that say to you? If I say that, it should speak volumes and make you or help you to understand why the elderly are dehydrated. Not only all of the things going on with their bodies, but also that they have a decreased urge to drink. They just don't have that thirst that we do in our younger years. Kidney is the major organ of water secretion. You need to understand that. We also will lose it through feces, perspiration, and breathing. We've already talked about it. We've talked about aldosterone levels, ADH levels, and atrial natriuretic peptide levels. Okay. So I don't want you to get too bogged down on the learning RAS again and all of that. There is an understanding you'll need to know for that, but at this moment in time for my students, don't bog yourself down with it. I want you just to understand what's going on with volume and what we're seeing as nurses with electrolyte imbalances and volume imbalances. We'll get into the nitty gritty. 102 is our friend. So let's talk good old science class. You got to remember these things. So, diffusion is a passive transport. It's a process where substances go back and forth until they are evenly distributed. Substances will move from a higher concentration to a low concentration until both sides of the membrane is equal. Now, here is a perfect little analogy. Do you all remember, and don't take any offense if this is you now by any means or your grandmother now, but my grandma loved that old Avon perfume. And I can't tell you the name of it, but if I smelled it today, I'd probably get sick. It was a very heavy floral smell, but you could smell her. She coated it on, right? She sprayed not one spritz on her, two spritz on her. She coated herself down with it. And she would walk in and you could smell her on the other side of a room. Well, this is diffusion. So she has a higher concentration of that perfume wherever she walks in and stands. Say she's in the corner of the room. I'm on the other side of the room talking to friends, whatever. In time, the smell will equal out. That concentration of her smell, that perfume will equal out, that everybody will smell it. But if you're standing by her when she first comes in the room, you're going to smell it immediately and you're going to smell how strong it is. But for me on the other side, I probably won't smell it right away, but as she moves or stands there and walks a little bit around on that side of the room, eventually I will smell her perfume because it's so strong. It will move across back and forth until it's equal around and everybody smells that lovely scent. Glucose, oxygen, carbon dioxide, water, and other small islands and molecules move by diffusion, just so you know. So here's a great picture. Greater concentration to lower. It's going to move that way until it's equally distributed. So remember good old osmosis, passive transport. It's movement of a pure solvent liquid across a membrane. It goes through that semi-permeable membrane, right? To get through to the other side. Water moves from an area of less solute concentrate to an area of greater concentration. So it's kind of opposite of diffusion. Diffusion is greater to lesser. Osmosis will be lesser to greater, but going through a semi-permeable membrane. So here's a great picture for osmosis, and it's just showing once again. Notice the arrows are going into the greater, so the lesser will go through. So if water goes over, like water is on that side of lesser, it's going to go over and it's going to dilute out into the whatever's on the other side that's in greater concentration. So filtration is next, which is also passive transport. It's movement of water and suspended substances outward through a semi-permeable membrane. So let's look at hydrostatic pressure because that's what we're talking about. Causes fluid to press outward on the vessel. It forces filtration. It promotes the filtration, forcing movement of water and electrolytes through the capillary walls to interstitial fluid. So, what organ creates hydrostatic pressure, do you think? Actually, the heart and the vascular system does. That's how it works. So, that pumping, it keeps things moving and pushing against the vessels so things can filtrate in and out. So here's a picture also with arrows going back and forth and all around, causing the pressure. It's causing things to move. It forces through that semi-permeable membrane the things to actually filtrate in and out according to what we want. Filtration is the movement of molecules between the semi-permeable capillary membrane, but it's dealing with pressure. It's a little bit different than when we're looking at osmosis, just FYI. So it's important that you just kind of understand that because that's what maintains our homeostasis is these things. So I don't want you to bog yourself down too much on these terms, but I want you to just go back. You should have been introduced to these terms in your science classes and courses that you've taken, but prior to nursing. So it should be more of a review. Active transport. It requires cellular energy. It can move molecules into cells regardless of their electrical charge or concentrations already in the cell. The energy source of the process is an adenosine triphosphate, which is ATP. So look at ATP as the gas for active transport. So the truck pulls up, ATP fills up the truck with the gas. You got to have it. It's the energy source that makes it work. And active transport is going to say, hop on in. I don't care who or what you are. I'm taking you to the next stop. So it doesn't matter what's going on. It's going to do it. Doesn't matter about that molecular charge or anything. It's going to move it no matter what if it's an active transport. But remember, it uses ATP, which that's the gas to move it. It moves amino acids, glucose, iron, hydrogen, sodium, potassium, and calcium through the cell membranes. That's how we move it, is through active transport. So this is just a picture of active transport for you to look at. Watch your arrows, kind of see what's going on and how it's working. Now, saying all of this, what we're looking at are people with volume deficits or overloads. We have excess or we don't have enough, right? That's the problem at hand. And when we have that problem, what are we looking at? What are we seeing? And what are we going to do as nurses? So let's just take a quick look at fluid volume deficit. This means we don't have enough volume in our bodies. There's a problem going on and the volume is gone. The patients that are at risk are unable to take enough fluid. And I want you to look at these people because this is the things you need to start looking at your patient. When you're assessing your patient, when you're looking through their history, if you see things that will trigger you to know they're going to have problems with fluid volume and most likely have a deficit. People with impaired swallowing, where do we get most of our volume? Through intake, right? Through eating and drinking. If they can't swallow, they're not going to eat or drink. So then they're going to be at risk of a volume deficit. Extreme weakness. If you're so weak, you don't want to eat. You don't necessarily need the energy, or you don't have the energy to eat, you're not utilizing because you're not doing anything, you're just kind of laying there, you're not really utilizing tons of energy, but there's still energy that is needed, and you got to have it to maintain life. And because of that, if you're just too weak, you're not going to pick the cup up and drink. You're not going to eat the food. You don't feel like you can. Have you ever gone through a spell where you've been ill or something and you've not been able to eat for a couple days and barely been able to drink, and then all of a sudden you're feeling better? Sometimes it takes a little bit for you to get back in the swing, or you'll say, I think I'm just going to have some chicken noodle soup today with crackers and maybe some 7 Up or Sprite or something like that. And the reason why is your body's just kind of weak. It just can't take on trying to digest a steak and baked potato. Disorientation or a coma. If they're in a coma, they're not doing anything. They're laying there, right? They're not going to eat or drink. It goes back to not being able to intake things, and also movement. Disorientation, they're disoriented. They're not going to know to drink or eat. Their mind's not there to be able to do so. And then the unavailability of water, and we see that in other countries. We see that in other areas of our country even. Think about it. Flint, Michigan, the water was horrible. If you couldn't afford to get bottled water and stuff, you probably limited your intake. You were only getting it from outside sources because the water was so bad. It was toxic, couldn't drink it. Patients who lose excessive amounts of fluid. Now, this is where we look at some disease stuff or things going on. Prolonged vomiting. If you vomit and vomit and vomit, that means everything in your stomach is coming up and out, right? Through the mouth. We're throwing it up. If that's the case and you have excessive amount or prolonged vomiting, you vomit once, you're going to be okay. Drink something, it's fine. You vomit a couple times, I'm concerned, but it's okay. Let's get that under control, clean you up, get you something to drink, see if you can keep it down, go to clear liquids. But if you throw up and throw up and throw up, you are at a high risk for dehydration. You are at a high risk for fluid volume deficit. And with that saying, you have lost electrolytes out of that vomit. We learned how to put NG tubes down. And when we're checking, either we're checking residual and we pull back and we measure residual, how much is left in the stomach, then we're going to put all of that back in. Evidence-based practice have told us that those are full of electrolytes and stuff that our body needs. Don't throw it down the toilet. We need to put it back in and then deal with whatever's going on. Now, if we have diarrhea, diarrhea is coming out the other end, right? But it is water. Our GI tract is a part of this process. We eat or drink, it goes through the system, through the stomach, absorbed down through the small intestine, large intestine, and then out, right? That is our GI tract. Starts from the mouth, ends at the other end. Well, diarrhea is excessive liquid stool. So when it's pulling all that volume, it's pulling those electrolytes out too. Pulling, and it's having you poop it out. Hemorrhaging. If you bleed out, just make a note in your notes, put a little red star by it. If you bleed out, you have to replace it with blood. If blood is lost, blood is the replacement. You can do things, and you'll learn that, later in emergency, but you can do other things to help maintain blood pressures and things like that if someone's hemorrhaging, but you're going to want to give them back blood. Diaphoresis, sweating. We have excessive sweating. I was cycling once. I used to bicycle a lot, road bike, and my friend and I were doing a 100-mile ride in a day. And we started out super early. We weren't super fast, but we could do it. We could ride about 6 to 7 hours normally, right? And so we needed to go a little further than that and pick our speed up a little bit. But we were riding, we were in Georgia, and we were in the summer of Georgia, or the end of spring in Georgia, actually, but it's warm down there. And we're not used to it from being in the mountains, and in the cooler areas of the humidity and stuff. And so we were riding and riding, and we were sweating. I mean, we were pouring it, and we were drinking. We were drinking the fluids, and we were doing a little bit of electrolyte replacements too. And we got about 30 miles out from finishing the ride, the day for the 100 miles, the century. And she started feeling kind of bad, my friend. And I said, "Are you okay?" And she said, "Yeah, I'm just, maybe we can stop, take a break, drink a little more and all that, just kind of rest, cool down." So we did. We got back on the bikes. We keep riding. We keep riding. The last 12 miles, she stopped sweating. And that's a big scary. I was getting scared. She was feeling worse, all that. We made it. We finished, but we had to do massive fluid replacement and electrolyte replacement and rest because she was getting pretty rough there towards the very end, can become dangerous. But if we have excessive sweating, we lose a lot of volume. That can happen. You've got to replace it. It's something to think about. When else do we sweat? If you have a high fever and you break that fever, lots of times you can have diaphoresis. You can sweat a lot. So just think, if anybody's sweating a lot, remember those old suits? You used to put these things on suits to lose weight. This is back in the 80s, but they were silver. They're still out there, but you put them on and they trap. Nothing moves. It all traps. It traps your heat within those things. They're little jogging suits. And so what you do is you put them on and go walk or exercise or whatever. Well, you have excessive diaphoresis, sweating. And so it helps you lose water weight, and we used to say this is what we would do. And we figured out that it wasn't the best thing to do in the world by any means. Excessive wound drainage. So we can go into a fluid volume deficit. So if you have a big abdominal wound and it's to a drain system of some form, there's different drains out there. If that's the case and you are continuously filling that up, every hour I'm having to dump that out. I need to be counting that as my output. Remember that. And that can cause fluid volume deficit. Now, all of these things I want you to see. Prolonged vomiting. If you're vomiting, you need to stop the vomiting. The vomiting needs to stop. If you continue to vomit, we're going to get nowhere. We can replace stuff, but if it doesn't stop, it's going to just continue, right? It's just in and out, in and out, and we're just going to never get better. Diarrhea, the same. So we can give an antiemetic for vomiting. For diarrhea, we need to stop it. It's an anti-diarrheal. We need to stop the diarrhea and then replace to where we get back to homeostasis and a normal level, volume level for our bodies. Hemorrhage, we got to stop the bleed. We got to stop the bleeding and replace with blood. And that's what if not, you're just going to keep bleeding out and you're pouring blood in. Eventually, what happens in all of these settings, if you don't fix it, they're going to succumb to what's going on because you can't keep up doing that. We've got to stop it. Diaphoresis or sweating, same thing. Stop whatever you're doing, cool down, stop the sweating process, and replace. And excessive wound drainage. Now, if they have excessive wound drainage, we need to be documenting that. We will need, the doctor's going to have to intervene, do something, but we need to be documented, understanding that if we don't stop this, it's going to be a problem, and letting our physician know so we can get orders to do whatever we need to do. He might need to go in and suture something up. I had an open heart patient once and came back. They have chest tubes in, and they're to drain excessive fluid after the surgery. And it's bloody at first for everybody, but it was bloody, and then it was more bloody, and then it never got less, and more volume came out, and this is just in a couple hours time. This isn't like days went on. But I called the physician, told him what was happening, just said, right now my vital signs look good, this is where we are, these are the drips we're on, but this is my chest tube drainage, and I'm just kind of concerned about it. And he said, I'm here, I'm gonna come up, I'm gonna take a look at my patient. So he came up, he looked, we talked about it, and he said, I think I'm gonna go ahead and take her back down to surgery, open her up again, take a look. So he took her down and he opened her up, and a good thing he did, because she had an arterial bleed, a little small artery is bleeding, and she would have just bled and bled and bled. There would have been nothing I could have done to stop that. So it's just important to understand, you got to stop what's going on, replace the volume, and then understand what volume you use to replace it with. So for this lady that went down for the open heart story, she needed blood. because she lost blood. That would be hemorrhaging. For sweat, it would be other IV fluids, also drinking if needed to be. Vomiting, diarrhea, definitely we need to be, and with sweating also, all of these we need to be thinking electrolytes and looking at lab values and then replacing the electrolytes that are needed. You've heard of Gatorade, guys. Gatorade was started by the University of Florida way back. Their football player, it's so hot down there, and they were all out there in their pads and everything playing. And they were like, we've got to give these guys something because they're just falling out on us. What are we going to do? And they created this powdered substance that they mixed in with water for them to drink. It tasted pretty good. And they could replace their fluid and electrolytes because they were losing them with excessive sweating out on the field in the Florida heat playing football. And that's how Gatorade, because it's the Florida Gators, that's how Gatorade was invented. But it's a great source. We still use it to this day. There's Powerades out there and some others, but just think about it. But if we don't fix fluid volume deficit, it will continue to spiral and we'll go into dehydration. Who's at risk? Poor swallowing. Anybody? Stroke patients. They have difficulty swallowing sometimes, just depending. People that have had oral surgery, have had nasal surgery, different things like that. They can have difficulty. Tonsils, tonsillectomies, right? All those things. Think when you think of poor swallowing, just think paralyzed people, um, anything that would weaken the swallowing of, and as we age, those muscles weaken, so we can have some issues and problems with swallowing. Decreased or depressed thirst, we've already talked about it. Weakness, confusion, fluid loss through drainage of wounds, we just talked about that. But diuretics, guys, we give diuretics to decrease volume in the body. We give it to pull fluid out so that the patient can pee it out. That's what a diuretic is going to do. But we have to be very careful. So if we're not careful, we're in overload, we give a diuretic, they can go to deficit. We've pulled too much volume off of them, and then we need to give them some volume back. There's this fine line. And how do we know that? We'll know it by vital signs, and we'll know it by our 24-hour I's and O's. By looking at that, you'll know if your patient is positive or negative. If you give a diuretic, you hope that they're in the negative because we're pulling it off, but we need to look at vital signs too. We're looking at our patient. What is going on? If you pull off too much fluid and there's not enough circulating volume and we're in a deficit, we're going to have a decrease in urinary output at a point. So we've got to kind of watch this. We're assessing and looking at this at all times. So if you have a patient on diuretics, they're at risk for dehydration or they're at risk for volume deficit. So what is dehydration? It's when too little water is in the plasma. The water is drawn out of the cells by osmosis to equalize concentration, and the cells will shrivel. So what happens is we don't have enough circulating volume. We don't have enough plasma, water. That's the water of the blood. We don't have enough of it in our and because of that, they're going to pull water from cells. The body's going to say, we've got to have it. We've got to have a blood pressure. So let's pull water out of the cells and try to shift it into our circulating volume. And so it says, out of the cell, sucks it up out of the cell, sends it into the circulating volume. But when it does that, it's going to cause our cells to shrivel, right? So that's not good either. When we pull volume out of the cell, then we start to alter our electrolytes. It's treated by fluid administration, either orally. We can either give them some stuff by mouth or both, or intravenously or both, oral or IV. What we do when we dehydrate, we can have different things. I'm going to go over signs and symptoms on the next slide. So I want to move on and then we'll talk about it a little bit more. So signs and symptoms of dehydration. These are things you need to hone in on, guys, because you're going to, what do I see? What am I assessing? And what do I need to do as a nurse? Those are the things you should be asking yourself over and over and over again. In the meantime, starting to pull. If I've got a patient, this is going on. This is going to create this issue. If I've got this going on, this is going to create this issue. You start to bring it together, guys. Pull it together slowly but surely. You're assessing. So we're going to see thirst. In the beginning of dehydration, they're thirsty. They want to drink because the body's saying, drink, I need fluid. And it triggers that hypothalamus and we start to want to drink, right? We'll have weakness, dizziness, postural hypotension, decrease. We're going to have a decrease in urinary output or urine production. The urine that we pee out, guys, that we urinate out, don't use the word pee in the clinical setting, it's urination or urine. Or micturate. The urine that comes out is concentrated. So it's going to be dark in color. It's not going to be that clear straw-like look, yellow. It's going to be amber in color, darker in color, more concentrated looking. And it's going to be less. We're not going to have as much. Dry, cracked lips, dry mucous membrane. So when you're assessing and you look in the mouth with your pen light, part of your assessment, look at their lips. We want to see what they look like. If they're dry, what do we want to do? One, we know they need hydration, but two, we might want to put, if they're mouth breathers, they could have dry lips too, just because they're right. And if that, or they're licking their lips all the time, that might have dry, cracked lips. But we want to look at their lips and do something about it. We can put stuff on their lips so they don't break open and bleed. And look at their mucous membranes. If they're dry, then we know that they're probably dehydrated. This is a good way to look at with children, small children. Thick saliva, dry scaly skin, poor tissue turgor, flat neck veins. You lay a patient back 30 degrees and you're going to look. If they have flat neck veins, you don't see anything sticking out that should, it could be an issue. Increased pulse rate. So we're going to have an increased heart rate or a pulse rate. That means they're going to be tachycardic. They're going to have a weak, thready pulse when we feel it. And they're going to have an elevated temperature. They get hot. Why does the heart rate increase? Why does our pulse rate increase? Well, we have decreased fluid or plasma volume. And so what happens is the heart's going, I need to pump more volume. It goes, I've got to do something. We need more volume. So how do I get volume out to the body? I pump. So it's going to start to try to compensate for the decrease, the dehydration, and what the decreased volume. And because of that, it'll pump faster. It's like, I need to pump, I need to pump, I need to pump, because it's trying to maintain homeostasis. It's trying to maintain a blood pressure. And because of that, my heart rate goes up. It's going to work hard. It's working that muscle. I got to have volume, got to have volume, got to have volume, got to have a blood pressure, got to have a blood pressure. And because of that, it just pumps and pumps and pumps. That's why it goes up. Why do you think our temperature goes up or elevates in dehydration? What happens with dehydration, it stimulates an inflammatory response in our bodies. And because of that, the body's like, whoa, and it causes the temperature to rise. Because when we have an inflammatory response, our body automatically goes, I need to raise the body temperature so I can kill anything or do anything that's causing damage or harm. So our temperature will elevate. Now, lots of times we'll see dehydration in the heat because there's different things that go on with heat. So if that's the case, then you want to remove them from the outside area or out of the direct sunlight or heat, put them in a cool place, let them start to cool down. Even if it's not that, let's just say something else is going on and you have a volume loss, you need to make sure you want to take them from take them out of that situation, and always lay people kind of in a cool area. Don't leave them in direct heat. That's never good, and especially with dehydration, remove them. If we want to test turgor, and this is signs of dehydration, we can test the skin turgor. If you can see in the picture, she's pinching up on the chest area. Now, what happens in the elderly is our skin loses that fatty layer. We get the thinner skin. We lose elasticity to our skin. So you can pinch on top of the hand and the skin might tint. It doesn't necessarily mean they're dehydrated. It just means they don't have enough elasticity or fat tissue up under there. That elasticity isn't there. So when you pinch it, it's going to stay tinted. So if you go to the chest area, right under the clavicle there, the collarbone, if you come down, you can pinch and it shouldn't tint. If it tints, it should be then let you know that there's probably this patient is dehydrated. Now, I'm going to go ahead and say this. I'm not as much about turgor. You should always check it. But I will say that some people have very crepey, non-elastic skin all over their body as they age. So you might do that anywhere on someone's body and it's going to tint. So it's not as accurate. But let me say this to you. Skin turgor, testing for tissue turgor, on younger people or healthy adults, not the elderly, but anybody else, it is a great sign. No child should you be able to pinch up and there be a positive skin turgor because they're hydrated. They have all the fatty tissues and they should have everything they need, the elasticity in the skin for it to go back down if everything's within normal. But if they're dehydrated, they're not. They will tint, and that's a big red flag. So just remember that. With the elderly, it's kind of hard. They have a lot of issues with loss of elasticity with the skin, but with anybody else, it's a great thing to do. But always check your skin turgor no matter what the age of the patient so that you at least have a baseline or kind of know what you're looking at in case someone else comes in and pinches it and it's different or goes back or whatever. So we've talked a little bit about dehydration or fluid volume deficit, FVD we saw in our papers. Let's look at excess. So we're in overload. That is not good either. We're not meant to be in overload. So healthy people do not ordinarily drink too much water. It's rare that you find anybody that's going to drink so much water that they've drowned themselves internally with it. Usually our society is on the dry side. Occasionally you'll hear of someone that's drinking gallons of water in a day and it causes them harm. So there is a balance to everything. When people become ill, they may take in more water than they excrete. Um, and that's just based on what's going on in the body. If you have a patient that has renal insufficiency, renal disease, end stage renal failure, all of those things, acute renal failure, they might take in more water, but the kidneys are unable to do what they need to do to filter, concentrate, and excrete that urine, the water, the volume. So there's just different things that could go on that make you hold on to water. Or you take in more and you just can't get it out. You receive IV fluids too quickly. If we open IV fluids and run them wide open, um, it can cause the patient to have overload. If we run a high IV fluid, like we start an IV bag and we've got IV fluids flowing into at a rapid pace, we're just giving them massive fluid quickly, even if it's not wide open, but we have a rate on there that's too high. And let's say they're having medical issues like heart failure or anything like that, then in that case, it can overload them. Given tap water enemas, so tap water enemas can cause fluid volume excess. What's in the tap water can be absorbed through that lower part of the bowel. It absorbs, it's very vascular, it can absorb. So if you put tap water enemas in, there's nothing in there that's going to pull. What's happening is the body will absorb, and because of that, it can overload with that volume. It's almost like drinking it too much water. So we need to be careful with that. Drink more fluids than they can eliminate. Any kind of disease process that causes a problem with elimination, we can have, but people want to drink, right? If that's the case, then we can have fluid volume excess. Lots of times, our renal patients, our kidney failure patients, acute kidney failure patients, stuff, you'll say to them, we need to keep you on a strict I&O, meaning we're watching every drop that goes in your body and every drop that comes out. If we have them on, the doctor says they can only have, let's say, 900 milliliters of fluid in 24 hours. That's where, as the nurse, you have to divide up how much. They can't just have a drinking cup on their table to just chug the water when they want. But what you find is when you start to limit patients' fluid by drinking, they'll drink from anything. I've seen them drinking out of the sinks in the bathrooms. One time I had a guy, and a gentleman patient, and he was not completely with his mind. He was trying to get fluid water out of the toilet to drink. He was that thirsty, but he was on a limit of fluid. And so we had to do some things creatively with him to keep him safe. Um, so how do we find or signs of overhydration? Weight gain. Anybody that we're watching and we're worried about them getting overloaded, we're going to weigh them, and we're going to weigh them with the same clothes on at the same time, on the same scale. So usually if they're home and we're worried about overhydration with a patient, we'll say, when you wake up, go to the bathroom, because most people get up and have their morning constitution, or at least they'll urinate. Have them do whatever they do in the morning first thing. Then if they weigh naked, weigh naked. If you weigh with your same nightgown on, weigh with the same nightgown on. The thing is don't weigh one day with the jeans and a big heavy sweater because you're going out into the snow, and then the next day weigh in your little lightweight pajamas. You're going to have alteration in weight, and we don't need that. It needs to be as accurate as possible and always on the same scale. Because I will tell you, I used to weigh myself on the scale at home, and then I'll go to Publix. Used to have this huge scale you could weigh yourself on. If you have it's a grocery store. If you have a Publix nearby, they used to have it, and I used to go get on the Publix scale, and it always weighed me heavier at Publix than it did. Now, why? Number one, I'm weighing at a different time in the day. Your weight, your vital signs, your sugars, all of these things fluctuate throughout the day based on what's going on. So the volume, so that's why it's always at the same time. The best time to get your weight or to tell or teach a patient is as soon as you get up in the morning, use the restroom so you empty the bladder. It'll be full from sleeping all night. If you have a morning constitution, meaning you have a bowel movement, go ahead and have that bowel movement. If you do it every morning, go ahead and do whatever you do. And then you need to immediately get up, put on or take off whatever you need to, and weigh yourself on that same scale and write it down, because you're going to think you're going to remember it, but you won't. So I always say, write it down. Get a little notebook or something and just make sure you write it down. You're going to find crackles in the lungs. Those are considered wet lungs. So it sounds like Rice Krispies. If you pour milk into a Rice Krispie, it's a cereal, and you get that crackly, crackly sound, that's what it sounds like when you're listening to lungs. You'll hear it. Once you hear crackles in the lungs, you'll never forget it. But it means that there's volume, fluid in the lungs. They're wet, and that's not good. If we overhydrate, we're going to back volume up into the lungs. We're going to have a slow bounding pulse. We're not going to be tachycardic. We're going to have a slow but bounding pulse. You can really feel it. We're going to have an elevated blood pressure and possibly edema. Excuse me. So for dehydration or fluid volume deficit, if we're dehydrated, we're going to be tachycardic. We don't have enough circulating volume. We're going to have blood pressure issues going down. We're going to have an elevated temperature, right? And then on top of that, we're going to have less urinary output. For overhydration, we're going to have a slow bounding pulse. We're going to have a higher blood pressure, right? Usually high blood pressure. We need to get that volume off, and possibly edema. So we're going to put it somewhere in the body. We're going to carry it with us, right? They're going to be swollen. So let's take a look. So here is a great example of pitting edema. We were talking about this in clinical the other day. So we have very swollen feet. They pushed in, those are fingerprints. If they stay in there, those indentions remain, the patient's retaining fluids. You push your fingers on the top of patient's foot or the ankle. You can also do the shin sometimes, that lower shin area if needed, if they're swollen all the way up. But if the indention remains, it's considered pitting edema, and we have different stages of pitting edema. This is not good. This is a bad pitting edema here, 4+. So let's look at sodium. I'm not going to read through all the electrolytes. We've gone over them. They're in the book, but they are here for you to kind of read through again. I want you to gather it so you understand it. I don't care if you have to draw an arrow on a piece of paper or whatever you need to do to understand what's up, what's down, what's going this way or that way. Do it your way. Establish your way of understanding. Create whatever study tool you need so that you can gather the information and create this. Hyponatremia, sodium deficit, vomiting or diarrhea can cause this excessively if we have this. Um, Hypernatremia is high sodium levels, excess, and there's some different things here about disease processes that you can look at. With sodium, think neuro. With potassium, always think cardiac. There are two major cations. So hypokalemia, we have a less than 3.5 potassium level. This can be from a poor diet, vomiting, diarrhea, excessive sweating, and diuretic therapy. Hyperkalemia is too much potassium. It occurs with burns, crest injuries, uncontrolled diabetes mellitus, or renal failure. We're holding on to potassium. Not good. Okay. So hypocalcemia, we have calcium. Um, it occurs with the deficiency of calcium. We're going to have a positive Shavastic sign. You need to know how to test for that. We've gone over it on the last one. Go to your book, look for that. We're looking at cranial nerve number 7. Remember that. We tap it and they'll have that twitching of the lip. Seizures, wheezing, swallowing problems. Hypercalcemia is when we have too much calcium, right? Anorexia, abdominal pain, renal calculi, kidney stones, fractures due to bone loss. So hypercalcemia is when the calcium will release from the bones, and because of that, we have too much calcium floating around, and then the bones become brittle. Not good. So on this slide, just remember if the calcium level's incorrect, I corrected them on some. I don't know if I corrected them inside the slides. If they are, just remember we use the ATI. We use those that I gave you. They are correct on the other slide. So remember, you need to know sodium, potassium, calcium, and magnesium normal levels. Hypocalcemia levels drop low, below the normal. It can occur with a nutritional deficiency. It occurs with disorders and a shift of calcium into the bone. So what do we have to do to absorb calcium? You need to know vitamin D, right? Got to have it. Know where we get it from. That's important. Hypercalcemia, we have too much. Most cases are related to hyperparathyroidism, or or a malignancy in which there is metastasis within bone reabsorption or resorption. So I want you to make sure you put hyperparathyroidism. We'll go through all that in detail, but this can cause hypercalcemia. Connect those two. You'll learn details later, but I want you to understand that we'll see it there. So the parathyroid plays into all of this. Hypomagnesemia, this is low magnesium. It's not hypomagnesium, it's hypomagnesemia. It results with malabsorption or malnutrition of renal tubular dysfunction. Thiazide diuretics can cause this. Extensive gastric suctioning or diarrhea will lose our magnesium. We also can have positive Shavastic sign, that's that twitching. Hypocalcemia and hypokalemia go with hypomagnesemia. Do you remember in my lecture, the last one I did, I said they're a gang, they stick together. So if you have one low, they're all low. They're all low. They're all out there in the streets doing their thing, right? Hypermagnesemia occurs only in the presence of renal failure. They just can't filter it, so they hang on to it. But we can have hypotension, nausea, vomiting, paralysis, respiratory depression, EKG changes. So this is one you need to know. So let's look at acid-base balance. And I do want you to really focus on this. This is something that you need to understand. So it's so important that we have the balance to maintain homeostasis once again. All of this plays. This is where life and death will take place if we don't keep our balance. So our pH, our normal blood serum pH, is 7.35 to 7.45. You need to know it. You just need to memorize it. It's right there in with your other values of the labs that I've told you to know. 7.35 to 7.45. Anything that is greater than 7.8 or less than 6.8 is death will occur. So if we're less than 7.35, we're considered acidotic. If we're greater than 7.45, we're considered alkalotic on our blood or serum pH level. Anything less than 6.8, that's severe acidosis, we will die. Anything greater than 7.8, that's severe alkalosis, we will die. There's not much give here. There's not much wiggle room here. You've got to stay within that to maintain homeostasis in life. We balance between the lungs, the bicarb, and the carbonic acid to keep that acid-base balance. And just so you know, carbonic acid is removed by the lungs, the respiratory system, and bicarb or bicarbonate is retained and removed by the kidneys. So the reason why it's important, you have to know, we're only going to talk about metabolic this semester. We'll talk about respiratory next semester. But for metabolic, we're talking about it. But when we're talking about acid-base balances, you've got to understand that the lungs and the kidneys both work to maintain an acid-base balance. Just so you know, lungs will kick in and work more quickly than and faster than the kidneys. The lungs are pretty quick to work and kidneys are a little bit slower. It takes a couple days sometimes for them to actually do what they need to do. What happens is if we need to hold on for some reason to our respirations to change or alter things where we either blow off too much or not enough carbonic acid, then our respiratory system will do so. We'll either be tachypnic and breathe really quickly or we'll breathe slowly. For kidneys, we're going to concentrate and we're either going to hold on to bicarbonate or we're going to release bicarbonate depending on what's going on so that we can maintain a normal acid base. So things to take from this of what I just said. Normal pH serum is 7.35 to 7.45. Anything severe, you're going to die. We need to maintain it. It's very small little room there for you to give. You can't get too much out of those parameters. The other thing you need to know, it takes the kidneys and the lungs to make this happen, to have an acid-base balance. And kidneys work slower than the lungs. So just so you know, lungs will immediately take off and do what they need to do, but kidneys take a little more time. It's a process. They're slower. So bicarbonate, the normal range is 22 to 26. Acts as a buffer to neutralize excess acids in the body, maintain bicarbonate to carbonic acid 20 to 1. Kidneys selected reabsorb or excrete bicarbonate to regulate serum levels and help maintain acid base. Now, your bicarb level, I do not want you to memorize this semester. You do not need to know it. If there is a question with bicarbonate, I will put the range on for you this round. Next semester, you will memorize it because you're going to have to be able to interpret ABGs. And to do that, you need to know your bicarb level. So, but bicarbonate, it is excreted and regulated levels through the kidneys. It's selective. The kidneys are dealing with bicarbonate. Just remember that. And carbonic acid, it's the lungs. So this is going to help you. If we want to maintain a normal serum pH of 7.35 to 7.45, we need to understand what controls this. Our blood buffer system also will help along the way. It consists of weak acid and weak bases. Our lungs, carbon dioxide and water are expired from the lungs. We got to remember that. And our urinary system, enzymes promote the dissociation of carbonic acid to free hydrogen ions. So our blood system has weak acid and bases. It tries to help us along. Our lungs, we're doing carbon dioxide and water. We're putting that out as we have an expiration. And then urinary system, we're going to do a control with our carbonic acid to free hydrogen ions. So these three systems also play. They help control our acid-base balance: blood, lungs, urinary. So metabolic acidosis, that's anything in our pH level that is less than 7.35. We have an excessive loss of bicarbonate ions or retention of hydrogen ions caused by, we can have kidney disease, diabetic ketoacidosis, circulatory failure, and shock states. Those are majors, right? Those are major system issues or disease processes that have caused us to go into metabolic acidosis. The one thing that's not listed here, but I want you to write in and I want you to hear me. If you have excessive diarrhea, you are going to go into metabolic acidosis. So just think of it this way. It comes out the bottom and we have metabolic acidosis. It's coming out that end and it's acidotic. It's acidosis. If I vomit excessively, it's opposite. And we'll talk about that with metabolic alkalosis. So, metabolic alkalosis, this is the loss of acid. We have too much acid gone. We're alkalotic. We have too much base now. The other one, we are holding on. We've lost our base and we have too much acid. This one, we've lost our acid and we have too much base. So we're trying to regulate this, right? The causes of this are vomiting. So it's opposite. If it comes out the bottom end, it's acidosis. If you vomited, it's alkalosis. Gastric suctioning, one of the biggest mistakes that we see in the facilities, the clinical settings today, is that people will hook a patient up with an NG tube, up to suction, and they need to be to suction. That's not the mistake. The mistake is we put them on continuous suctioning. So all we're doing is pretty much suctioning everything out of their stomach. It's just as if they stood there and threw up and threw up and threw up and threw up and never stopped. And because of doing that, by suctioning, continuous suctioning, we'll throw them into metabolic alkalosis. We've pulled off all their acid. If that's the case, we need to put the NG tube. If we need their stomach suction, we go to intermittent suctioning. That means it'll suction, it goes up, and then it stops. And it allows everything to sit in the stomach and do what it needs to do. It's never going to eliminate everything out of the stomach like continuous gastric secretioning or suctioning. Suctioning. Sorry about that. So just remember this: whenever you hook your NG tube up to suction, you need to make sure that you have it on intermittent, unless you have an order. But if you have an order, you need to question it. You need to watch your patient, because you will easily throw them into metabolic alkalosis. The other thing is, though, is let's say we have a patient with an NG tube down and you've put them up to intermittent suction, but they've been on it for days and days and days. Then we can create this alteration in acid-base balance. So we need to know, if we've got a patient that's up to suctioning, always put them on intermittent so we can hopefully prevent this. And then secondly, always watching our patient for metabolic alkalosis. Excessive antacid consumption. There are people that do it. So remember what Tums, we start to do all these antacids that have bicarb stuff in them and all. We can have issues with that and we can throw ourselves in metabolic alkalosis. Diuretic therapy can cause it. Potassium deficit. So if we have a potassium, if we're hypokalemic, we can be in metabolic alkalosis if we're not careful. So those are things to understand, because you might get a patient that has this. Let's say you have a patient, you're presented with a patient, a 32-year-old female that has been vomiting for 3 days and has been running a fever. Okay. And, hasn't been able to take anything by mouth for 72 hours. I mean, we're going to think dehydration. We're going to think metabolic alkalosis. What do we need to do? Well, we need to, one, stop the vomiting. We need to, two, replace fluids, but then we also need to correct anything to get them back into a normal acid-base balance. The last two slides are acid-base balance for respiratory acidosis and respiratory alkalosis. At this point, I do not want you to learn those. For anybody else out there that just wants to know, if it's acidosis, we'll have increased carbon dioxide levels. If it is, and I'm just going to flip to the slide, if it's alkalosis, it's where we have too much base. We're not acidotic, we're alkalotic. So we'll go over those more thoroughly for my students next semester. But for this testing, for 101 for our semester, we're looking at metabolic acidosis and metabolic alkalosis. So this is the last slide on this lecture. It's been an hour and a half. It's a long one. Listen to it. Take your notes. Listen to it again if you need to, whatever. Get your notes together. Look at your ATI. That's what we use for books. This is not an ATI slide, though, just FYI, because they say do not use our stuff. One of the things that I want to say to you guys is that it's so important that you start to think about, what am I going to do as the nurse? What am I seeing? What am I assessing? And what am I going to think about? What do I need to do? If I've got somebody with excessive diarrhea or a child with excessive diarrhea, I'm going to think dehydration, and I'm going to think metabolic acidosis automatically. Start to put it together. So if you see something, you can understand. Stop the diarrhea. That's what we have to do. We got to give them something to stop it. And how do we stop diarrhea? It's with an antidiarrheal. Now, we don't prescribe that. The doctor will, or the nurse practitioner or the PA. The practitioner will prescribe it. That is out in our scope to do. We don't do that. But what do we do is we report that. We've assessed it, we report it, and we document that we did to that provider, and the provider needs to give us whatever the order for us to, give them the antidiarrheal and stop the diarrhea. Then we need to replace the volume, and we need to replace the electrolytes. And doing all of this, we'll either be too acidic or too alkalotic, but we can control and make things better by how and what we give. Now, on this slide or this lecture, I don't have a lot of the hypotonic, hypertonic, and isotonic solutions. You will need to know that for my students for testing purposes. Remember, isotonic is equal. That's our normal saline D5LR. We've got hypertonic. It's going to shrivel the cells. Remember that? It pulls fluid out of the cell and into the vascular system. And we need to worry then about overload, but it's going to shrink the cell. What are those solutions? I just want you to know them. And then if we are hypotonic, I always think hippo. I've learned that from 20 years ago, hippo. And so we think big fat cells, we're pushing fluid into the cell. And so know those fluids that I've listed for you. You need to understand that, because if you are asked to get an isotonic solution, you need to, and they tell you to go get something that's not isotonic, but you're going to give an isotonic solution, you need to say, this isn't correct. There's something wrong here. Or if you're hanging a fluid as a nurse, you're going to look at it and go, oh, this is a hypertonic solution, and this can do this and that and this. And so I want you to just know how to identify them for right now and what they do to the cells. They either stay in the vascular system, they don't cause any kind of osmotic pull, any kind of anything. They just stay right there. Nothing comes or goes. But if I use a hypertonic solution or I use a hypotonic solution, I'm going to pull in or out depending on what I'm using. I hope this helps. For my class students, we will be live Friday. I will see you in Collaborate. And if you have any questions, please reach out to me. Anybody else, you can message me or whatever. through YouTube. For my students, you've got my email, my cell number, all that good stuff. So please just reach out.